Imagine walking into a hospital and wondering, not if you'll be cured, but if you'll be experimented on. Imagine knowing that, for generations, people who looked like you were used as test subjects without consent, without anesthesia, and without justice. Imagine trying to trust a system built on your community's suffering. This is not science fiction. This is the foundation of American medicine. And it's why, even today, the ripple effects of that past are still felt in who gets care, who gets believed, and who gets left behind. In the United States, the relationship between medicine and race isn't just strained, it's broken in ways most people don't understand. The term medical apartheid refers to the historical and ongoing racial segregation, exploitation, and inequality embedded in healthcare systems. It's also the title of Harriet A. Washington's groundbreaking book, which documents how Black Americans have been used as unwilling participants in the development of modern medicine. It's a story that doesn't appear in most textbooks, but it shapes healthcare outcomes to this day. Let's go back to the 19th century. The man often called the father of modern gynecology, Dr. J. Marion Sims, conducted painful experiments on enslaved Black women without anesthesia. His research helped him develop techniques that advanced surgical medicine, but at a devastating human cost. These women couldn't consent. They were seen as property, not patients. Their suffering was rationalized by a racist belief that Black people didn't feel pain the same way white people did, a myth that still lingers in modern medicine. Fast forward to the 20th century. The Tuskegee syphilis study is perhaps the most infamous example of medical betrayal. From 1932 to 1972, the US Public Health Service tracked the progression of untreated syphilis in 600 Black men in Alabama. The researchers told the men they were being treated for bad blood, but they weren't given medicine, even after penicillin became the standard cure. Instead, their bodies were studied as they slowly deteriorated. Dozens died. Many infected their partners. Children were born with congenital syphilis, and all of it was sanctioned by the federal government. This was not an isolated case. Throughout the 20th century, Black, Indigenous, and immigrant women were subjected to forced sterilizations, often under the guise of population control or public health. In many states, eugenics programs targeted women deemed unfit to reproduce. That often meant women who were poor, disabled, incarcerated, or simply not white. These procedures were sometimes performed without the patient's knowledge, signed away with medical jargon or hidden under anesthesia. The trauma of these violations doesn't end with the individuals who endured them. It's passed down through stories, through mistrust, through cautionary warnings whispered across generations. And that mistrust isn't irrational, it's survival. Even today, research shows that Black patients receive less pain medication, fewer diagnostic tests, and slower referrals than white patients with the same symptoms. Pregnant Black women in the US are nearly 3 times more likely to die during childbirth than white women. And studies have found that some medical professionals still hold false beliefs about biological differences between races. This isn't just a matter of bedside manner, it's a matter of life and death. But it's not just doctors and hospitals. In the digital age, health disparities are being amplified by algorithms. Just like in other sectors, AI tools used in healthcare reflect the biases of the data they're trained on. A widely used risk prediction algorithm was found to underestimate the health needs of Black patients, making them less likely to receive necessary follow-up care. Why? Because it used healthcare costs as a proxy for health needs. Since Black patients often receive less care and therefore generate lower medical expenses, the algorithm wrongly assumed they were healthier. And then there's social media. During the COVID-19 pandemic, Black and brown communities were hit disproportionately hard. But when misinformation flooded platforms, these same communities were also targeted with anti-vaccine propaganda, conspiracy theories, and false cures. The platform's algorithms often prioritized engagement over truth, boosting viral posts with emotional or sensational content, even if it endangered lives. This is the modern face of medical apartheid, a system where historical trauma meets digital bias, where centuries of exploitation are repackaged in the form of neutral tech and personalized healthcare, while the underlying inequalities remain. So how do you rebuild trust when the entire system was built without it? The legacy of medical apartheid isn't just about old records and horror stories from the past. It's about how those stories shaped behavior, how communities respond to medical advice, how they interact with healthcare institutions, and how they protect themselves from harm. Mistrust is not a flaw, it's an adaptation. When a mother hesitates to take her child to the hospital because she's afraid of being judged, when a man refuses to enroll in a clinical trial because he remembers what happened in Tuskegee, when an elder warns against experimental procedures, it's not paranoia. It's a defense mechanism shaped by generations of betrayal. And unless healthcare systems reckon with that reality, these disparities will never go away. Here's what makes the current moment so dangerous. Technology is moving faster than trust can catch up. During the pandemic, the rapid rollout of vaccines and health protocols collided with centuries of skepticism, and social media became the battleground. Disinformation campaigns targeted Black and brown users with laser precision, fueled by algorithms that reward emotional reaction over factual accuracy. Conspiracy videos spread faster than CDC guidance. Mistrust turned into isolation, and in many cases, people died because the truth didn't reach them in time. Even now, health misinformation continues to circulate more heavily in marginalized communities. Why? Because when the official channels have failed you for decades, you turn to alternative ones. And those alternatives, forums, influencers, TikToks, aren't regulated. They're optimized for engagement, not ethics. Meanwhile, big data continues to reshape how care is delivered. Predictive analytics now drive hospital staffing, patient scheduling, and resource distribution. AI is being used to flag patients for mental health risks, prioritize organ transplants, and even diagnose diseases. But when those tools are trained on biased data or rolled out without community input, they can deepen inequality, not solve it. Think of it like this. If you feed a system 100 years of racist medical history and ask it to optimize care, it will optimize for the past, not for justice. But this is where we can flip the narrative. Because the story of medical apartheid isn't just a warning, it's also a map. It shows us where harm happens, where trust breaks down, and where healing needs to begin. The solution isn't just better tech, it's better accountability. We need policies that ensure algorithmic transparency in healthcare. That means patients should have the right to know if an AI is involved in their treatment decisions. We need community-informed data ethics, meaning marginalized communities must have a say in how their health data is collected, stored, and used. Consent must be real, not buried in fine print. Medical schools need to overhaul their curricula, not just to teach about health disparities, but to trace their roots. The history of experimentation, neglect, and exclusion must be part of every medical student's training, not as a footnote, but as foundational knowledge. We also need representation in research. Clinical trials still disproportionately exclude people of color, which skews outcomes and limits effectiveness across diverse populations. It's not enough to invite communities in at the end of the process. They need to be part of the design, the implementation, and the oversight. And on social media, Platforms must take responsibility for the spread of dangerous health misinformation. That means investing in culturally competent moderation, flagging disinformation campaigns faster, and promoting reliable community-based health voices that users can actually trust. But perhaps most importantly, we have to listen. Not with defensiveness, not with data first, but with humility. When people say, "I don't trust the system," the answer can't just be, "Well, you should." It has to be, "Tell me why and how we can change that." Because rebuilding trust is not a PR campaign, it's a generational project, and it starts with acknowledging the full weight of history. Medical apartheid didn't end with Tuskegee. It's not confined to backrooms or old textbooks. It's in the policies, the platforms, and the protocols that still treat some lives as less urgent, less believable, or less worthy of care. The question is, who gets to build the future of healthcare? And will they build it with justice in mind, or just with efficiency?